with Professor Mark Salzer, who is from Temple University. And Mark, you run a rehabilitation department, rehabilitation sciences department at Temple University, and you're also part of a collaborative project. What is the collaborative?
Right, so we have a federally funded center funded by an institute called the National Institute on Disability, Independent Living, and Rehabilitation Research that funds centers in the states on different disability topics, different disability populations. And we've been fortunate to be funded for the last 13 years to focus on community living and community participation of adults with psychiatric disabilities.
Okay, and so when you spoke at the conference here, you talked about the fact that about the stories we tell about people with psychiatric illnesses or psychosocial disabilities. Why do the stories we tell matter so much?
Right, so the idea is that our beliefs as providers or even community members or policymakers can influence the kinds of decisions we make, the kinds of policies we set up, the type of clinical or rehabilitation care we set up. There's actually some research in the education area called the Pygmalion Effect, and it actually comes from an old Greek myth about a man who fell in love with a statue, and his love was so strong that the statue came alive. And I'm actually not sure exactly how the ending went. I'm sure there was something tragic about it. The statue fell on top of him or something. But the idea is that our expectations can make things happen in ways that we don't anticipate.
So I've heard it put this way: if you treat people like wolves, they'll behave like wolves.
Absolutely, and there's research in the educational settings that teachers who interact with school children in a particular way, especially ethnic or racial minorities or girls or whatever, you have an expectation as a teacher, you'll in some ways bring out those expectations,
that behavior.
Reinforce it. So girls might get the message that they're no good at math and science and
can't do sport, or
and certain populations might get messages that their people are no good or something like that. So the idea is we're trying to bring the Pygmalion effect, that notion, into mental health to help us understand that this could be present here. And there's ample research suggesting that providers in the general population have similar attitudes and beliefs as the general population. So one thing that I do is I look at these stories. I think it's a nice way.
So the story would be that we are assuming all sorts of things about people with a mental illness, or that we're assuming there's all sorts of things they can't do because they're sick, so therefore they can't do this. Maybe they can't work, or they can't study, or they're unlikely to form ongoing relationships. These are the stories we tell ourselves about mental illness?
So those are some of the stories. What I try to do, though, is ask people to tell a story in a very innocuous way. They don't know exactly what I'm getting at. So if you ask somebody with a mental health provider, oh, what do you think of someone with schizophrenia, for example? They'll say, oh, wonderful. They can do all sorts of terrific things and live in the community like everyone else.
Because they know that's what they're supposed to say, right?
They know that's what they're supposed to say. Yep. But if they have somebody like me saying, tell a story about a man named John, who's 34 years old and has been diagnosed with schizophrenia, they might tell me a story about John's symptoms and how many times he's been hospitalized and he doesn't take his medications and he's homeless and he's committed a violent act or something like that. And the idea is that if that's the first notion that comes to mind, it's almost a projective technique. I'm not a psychodynamic or analytic psychologist, but it is somewhat consistent with that. If that's the first story you tell, that might reflect the type of behaviors you might engage in. And the alternative to that John the patient story is telling a story where you understand John. You don't ignore the illness or the diagnosis or say that nothing's happened in his life related to that issue, but you talk about John's relationship with his siblings and his parents and his desires and hopes and dreams and those kinds of things. And we believe that people who tell those types of stories are much more likely to understand community inclusion and promote empowerment and really facilitate recovery.
And so this is really, it's drawing, I think, on the work of Amartya Sen, the Nobel Prize-winning economist and philosopher, to concentrate on people's capabilities and enhancing their capabilities rather than focusing on the disability, if you like.
That's right. Taking people for their uniquenesses and abilities and promoting that. And Armacho-sen is absolutely right. It's good for society, good for our economics, it's good for people's health, and it's a human rights issue as well.
Okay, and so once we start telling the stories in this way about people's lives, their hopes, their aspirations, the things they want to do, then we start moving towards, well, how do we facilitate that, right? How do we include people with mental illness in the life of the community just like anyone else?
Yeah. So there's no magic pill or magic method to this. It takes a lot of work. Actually, the first thing I always like to talk to people about is the fact that community inclusion is about all of us and participation is about all of us, and we all can relate to that. So there are things in my own life that I would like to do more of that are important to me and I don't do enough. Maybe make it to the gym more often. I'd like to, I mentioned that today is my 22nd wedding anniversary. I'd like to go out to dinner more often with my partner or see movies or do something. So we all experience community inclusion type of issues and that participation. The type of work that we focus on for promoting community inclusion is based on the notion of social model of disability. And this is in contrast to what's called the individual model of disability, which is someone with schizophrenia, for example, isn't working because he has schizophrenia. That explains
something
everything.
Wrong with the chemical balance in his brain or whatever it might be.
Something wrong with him, and we need to fix him, and that'll make the disability go away. Or he'll
like
suddenly
taking
be
your
able to
car to
work.
the mechanic and cleaning the spark plugs and giving it a service and then off it goes.
Or some people believe, well, you have schizophrenia, you can't do that, so there's no way we can fix this.
We're just going to manage it.
And social model of disability believes that the lack of participation, the disability, results from a person-environment interaction. So you could do nothing with John, right? John might have differences, right? He might behave differently or think differently, or who knows, maybe think he's Jesus Christ or whatever, but it doesn't mean John can't work. And it doesn't mean that we can't do something to the environment that's limiting somebody like John from working. So John might go to an employer, do an interview, maybe he's a little socially different, right? He interacts differently. I tell a story about a man I know who has challenges looking people in the eyes. And we've spent a lot of time developing evidence-based practices in mental health to fix people's social skills deficits, their differences. First of all, I know plenty of people without mental illnesses who have social skills deficits.
Some of them still have jobs. In fact, some of them lead countries. But anyway, that's another question.
That is exactly the point, actually, that people, even with these differences, can work and can go to school and can date and do all these kinds of things like anyone else. So the idea for promoting community inclusion and full participation is providing those supports, peer supports, natural supports. There are lots of evidence-based practices to support people's participation, while also, and equally as important, addressing those environmental barriers, the thing that limits John or Jane or Sue from participating.
Okay, so I want to come back to those environmental barriers, but first the response is going to be from some people are going to say, yeah, but surely we need to fix John to a certain extent first. You know, we need to stabilise his illness. We need to make sure he's taking his meds or whatever it may be. We need to deal with his substance abuse problem, or we need to do that before we can include him in a workplace. Isn't that going to be the response you run up against?
Well, it's absolutely the response. Actually, I just ran into a gentleman who told me that was the response to him. I think I ran into somebody else before, a young woman, who said the same thing, that he was told he needed to do all these things first.
And then they might help him get a job.
And then they might be able to do this. And the bottom line, from an evidence-based or a research standpoint, and again, I am a researcher primarily, there's no good evidence that this readiness notion is a good notion. We don't have good data that as clinicians we can predict whether or not somebody can be successful or not. We certainly know that people have issues, and maybe some issues that might be more encompassing of somebody's life or less, but it doesn't mean that those individuals can't participate in some ways. I knew a gentleman, I've worked in locked acute psychiatric units. I've seen people who've had very challenging issues in their lives. One gentleman who's probably had as many encompassing issues. There weren't a lot of times where he would interact like other people. But this guy was very savvy related to some work issues. He was able to do things in his own way, and if the environment worked with him to welcome him, he was successful. So readiness, the notion of readiness, that we need to fix the symptoms or fix the interpersonal skills or fix the cognitive functioning or fix whatever first, is not an evidence-based practice.
Okay, so this seems to be similar to me to the idea of housing first. So the housing first approach, as I'm sure you know, is an idea where we say, well, the traditional housing model is, well, we can help you find housing and get off the street, but first you need to deal with your substance abuse problem, or first we need to address your mental health issue, or whatever it may be. Whereas the housing first approach is say, let's get you into housing and worry about the other stuff later, because if we can put you in secure, long-term housing, then we've got a platform on which we can go to the next step.
Well, that is exactly actually the evidence that we point towards for why not only do we not have support for readiness, but we have support for interventions that don't require readiness assessments or anything like that. That the key factor is the person says they want to work. The person says they want housing. The person says they want to go to school. They say they want to date. They say they want their custody back of their children. We support them and move forward with their participation that way. These are actually this kind of research is what we included in a document we produced called Well Together. For my fellowship, they've commissioned us to pull this evidence together and some of the other things that we're talking about into one document.
And then you talk about the barriers to this kind of process, so the barriers to someone who's living with a mental illness to actually get into it. Now, seems to me to be really hard stuff, because the barriers are often deeply entrenched social prejudices, and they don't go away easily. And it's not easy to deal with that sort of culturally entrenched prejudice.
Yeah, I mean, this is clearly the biggest thing, and probably a reason why providers and policymakers haven't fully invested in trying to make these kinds of things happen, because addressing public stigma and discrimination and poverty issues and transportation and access to resources, these are big things that affect many people in our societies around the world. But it's important for mental health sector, for individual agencies, for individual providers to at least take a crack at that. Because if we're not addressing these barriers in some way, we're probably missing the boat to a certain extent in achieving positive recovery, inclusion, and mental health and wellness. We need to take a crack at it. There's also strategies for addressing barriers at the individual level as well, though. So if there's a provider who's saying, John shouldn't go to work, shouldn't go to school, shouldn't do these things, that is an individual level example of prejudice and discrimination. So as providers, we can work with that psychiatrist, social worker, organization to say, or policymaker, and say, hey, this individual, well, actually, I should stick with the individual. This individual really can't do it. There's evidence, and how do we support them in achieving that? So we can address barriers at the individual level. We do a little bit of work with religious organizations to talk about how they can be more welcoming of people, including at the individual level. If somebody's had a bad experience in church, done something, or engaged with people in a way that made them uncomfortable, we can go to the minister or something like that and talk about what can we do to support this congregant? And so that's what we can do to address barriers at the individual level.
So overall, could I summarize your message this way, that our tendency is to focus on fixing the individual, giving them some pills or some therapy that will fix that individual and enable them to fit in, to fit back into the society. And what you're saying is actually we need to put just as much attention on fixing the environment and creating an environment which enables people to be who they are and to participate fully, regardless of who they are.
And I couldn't have said it better myself, and if you want a director position, just let me know. You can come over to the States and run my center. That is exactly it. That's exactly it.
Okay, Mark Salzer, thank you very much.
Yeah, thanks, Peter.